Welcome back. Let's jump in and apply what we have learned about neurotic disorders. Patient number one. EMS is called to a 24-year-old male at a busy shopping mall. The 911 call indicates a possible heart problem. The patient suddenly felt intense fear and chest discomfort while shopping and is now unable to breathe. On arrival, you find a young man on the floor, surrounded by concerned bystanders. He is hyperventilating and saying he can't catch his breath. He clutches his chest, reporting chest pain and a pounding heartbeat. His fingers are tingling, a symptom of low CO2 from rapid breathing. He's visibly terrified, repeatedly shouting, "I think I'm dying and don't let me die." This level of fear and physical reaction is strongly suggestive of a panic attack, but you must approach systematically. Initial assessment. The patient is alert but in distress. Airway is clear. He's able to speak between gasps. Breathing is fast, but lungs sound clear. Pulses are rapid. Vital signs: HR 130, RR 40, BP 150/90, SpO2 99%. The high oxygen saturation and clear lungs make a pulmonary issue less likely, but tachycardia and chest pain raise concern for cardiac problems. Medical rule out. You attach the monitor for an ECG if ALS is available. It shows sinus tachycardia, a fast heart rate, but normal rhythm. No obvious signs of acute myocardial infarction on the ECG. You gather history. No cardiac history. This has never happened to him before. He'd been slightly stressed. He misplaced his wallet before this sudden episode. No drug use reported. No trauma. Your management. You suspect this is a panic attack because the sudden onset, intense fear of dying, classic hyperventilation, normal O2, and context of emotional stress. However, you continue to treat it as a medical emergency until certain. Begin calming measures. You move him to the ambulance, away from the mall crowd, to reduce stimuli. Speak to him in a steady, reassuring voice. "I'm here to help you. I know you feel like you're in danger, but I've got you. Let's work on this together." You acknowledge his fear while assuring him you'll stay by his side. You avoid saying "calm down," but instead guide him. "Slow your breathing if you can. I know it's hard. Follow my pace." You even show him the pulse oximeter reading, 99% O2, to prove he's getting enough oxygen. This often helps alleviate the "I can't breathe" fear. No paper bag. One bystander suggests making him breathe into a paper bag. You, as a trained EMS professional, do not do this. It's an outdated practice that can be dangerous if the patient has any medical illness. Instead, you continue verbal coaching to control his breathing. Monitoring and support. You keep him on the cardiac monitor and pulse ox just in case. After a few minutes of focused breathing exercises and your calm reassurance, his breathing slows and the tingling in his hands improves. His chest pain also eases once he's breathing normally. It was likely due to muscle tightness and hyperventilation. Outcome. After about 10 minutes, the worst of the attack has passed. Panic symptoms usually peak within 10 minutes. The patient is embarrassed but grateful. You explain that what he experienced is called a panic attack, a type of anxiety event that feels like life or death but isn't physically harmful in itself. Nevertheless, you recommend he be transported to the ER. He agrees, understanding it's important to make sure everything is truly okay, and this was his first episode, so medical evaluation is prudent. En route, he remains stable. You continue to talk with him, discussing possible follow-up, seeing a doctor or mental health professional about these attacks, especially if they recur. You mention there are treatments for panic disorder and even share info about the mental health crisis line for immediate support if he ever needs it. This scenario highlights a classic panic attack call: a young, healthy patient with sudden extreme anxiety symptoms. Key takeaways for EMS: always evaluate medically. Don't assume it's just panic, but provide empathetic coaching and avoid harmful interventions, like bag rebreathing. Often, compassion and time are the best treatment. As the patient sees that you're not alarmed and hears your steady voice, they begin to calm, and the body's panic response subsides. You serve as the bridge to further care, ensuring the patient is safe and knows this experience, while frightening is manageable and treatable going forward. Patient number 2. EMS is dispatched for a 58-year-old female with chest pain. The caller, her husband, reports she has a history of high blood pressure and severe anxiety. Tonight, after a heated family argument, she developed crushing chest pain and is convinced she's having a heart attack. You find the patient sitting on a couch, sweating and clutching her left chest. She appears very anxious, tearful, and is breathing a bit rapidly. She says the pain started during an argument with her adult son about an hour ago. The argument was very upsetting, and shortly after, she felt chest tightness, which made her panic, and the pain got worse. Now she rates it 8 out of 10. She also complains of feeling a little lightheaded and has some numbness around her lips. She tells you through labored breaths, "I have a lot of anxiety, but this feels different. I think it's a heart attack. Please don't let me die." She has no diagnosed cardiac history, but her father died of a heart attack at 60, and that is fueling her fear. Assessment. This is a high stakes situation because it could be an acute coronary syndrome or a severe panic attack or both. Anxiety can accompany heart attacks. You immediately perform a focused exam and vital signs. Airway and breathing, airway open. She's breathing fast, 22 times a min, but not extreme. Lungs clear. Oxygen saturation is 98%. Circulation, pulse is 110 and regular. Blood pressure, 160 over 94. Skin is a bit clammy. These could fit either panic or a cardiovascular issue. 12-lead ECG, you acquire an ECG early, critical for chest pain. It shows no ST elevations, no acute ischemic changes, maybe just sinus tachycardia. While not definitive, women can have atypical ECGs and MI, it's somewhat reassuring. History. Ask about specific symptoms. Does the pain radiate anywhere? She says no, it's just in the center of chest. Any other symptoms like nausea, vomiting? She has mild nausea, which can occur in both anxiety and MI. Any shortness of breath? Mostly due to her feeling panicky, she says. You ask her to describe the pain. She says it's a tightness and heaviness, not sharp. Heavy chest pressure does raise concern, but anxiety chest pain can also feel that way. She notes she's had similar chest pain in the past during panic attacks, but never this bad. Treatment on scene. Following chest pain protocol, you administer aspirin. Since an MI hasn't been ruled out, aspirin is low risk and high reward in case it is cardiac. Meanwhile, you use grounding techniques to address her anxiety. You have her do slow, deep breaths with you. You speak softly. I know you're really worried. We're doing all the right things. Your oxygen is good, and the ECG doesn't show a classic heart attack. Only paramedics can interpret the ECG if on an all BLS or non-paramedic ambulance, transmit the ECG to the nearest hospital for interpretation or follow your guidelines. That's a good sign. We're not out of the woods, but it's encouraging. Focus on my voice and breathing. You also ask what usually helps when she has panic attacks. She mentions she sometimes uses a prescribed alprazolam, but she hasn't taken it today. Since she's still very anxious, if you have ALS capability, you call medical control and get permission for a small dose of IV benzodiazepine to see if calming her anxiety relieves the chest pain. You administer a low dose of midazolam. Within minutes, she seems a bit calmer. Her breathing slows, and she says the chest pain is subsiding. This response further suggests it may not have been a heart attack, which usually wouldn't just disappear with relaxation meds, but you remain cautious. If you do not have ALS capabilities, keep reassuring and calming the patient throughout your time with her. Transport. You package the patient and begin transport to the ED. Any chest pain of this nature warrants evaluation. En route, she's much calmer. She even apologizes for making a fuss. You reassure her that calling 911 was the right move. Chest pain should never be ignored, and it's always better to be safe. By showing her empathy and not making her feel bad about it, you reinforce that she did the correct thing. At the hospital, further tests, troponin, etc., confirm it was not a heart attack, but likely an acute stress response, an anxiety-induced episode. The patient is relieved. The ED physician explains that intense emotional stress can precipitate chest pain and panic symptoms, and even causes a syndrome called broken heart syndrome, Takotsubo cardiomyopathy, in rare cases. In her case, it appears to have been a panic attack with chest pain as a prominent symptom. This scenario underlines the importance of treating all chest pain as cardiac until proven otherwise. Even though anxiety was suspected, given the context of an argument and her history, you performed an ECG, gave aspirin, and transported. Those are non-negotiable when cardiac etiology is possible. However, you simultaneously used your communication skills to soothe her, which not only improved her symptoms, but is also good medicine. Calming reduces myocardial oxygen demand if it were an MI, and of course helps resolve a panic if that's the cause. Dual approach. Manage the worst case, heart attack, while addressing the likely case, anxiety. The outcome here was good, and the patient received appropriate care for both possibilities. As EMS, you acted as the critical first link in her chain of care, balancing medical interventions with emotional support. And let's wrap up with patient number 3. You are dispatched to the home of a 35-year-old female with a complaint of severe abdominal pain. Dispatch notes indicate frequent caller, multiple past calls for pain with no findings. This suggests you might be dealing with a patient who has a somatic symptom disorder, where psychological distress causes persistent physical complaint. The patient meets you at the door hunched over, holding her abdomen, moaning in pain. She appears anxious and frustrated. She immediately says, "It's happening again. I have horrible pain in my belly. It's 10 out of 10. I know something is wrong, but the doctors never find it." She has a large binder of medical records at the ready. As you talk, she volunteers that she's had every test under the sun: multiple ER visits, CT scans, ultrasounds, endoscopies. And they always say they're normal, but I know this isn't normal. Her vital signs are all within normal limits: heart rate slightly elevated at 100 from pain and anxiety, BP 130 over 84, not febrile, etc. She has no signs of acute abdomen on exam, soft belly, no guarding or rebound tenderness when you palpate, which is inconsistent with her 10 out of 10 pain report. She tearfully describes a long history of chronic pain migrating through different body parts over the years, sometimes abdominal, sometimes headaches, sometimes back pain. Tonight, she had a stressful day at work, and now the abdominal pain is flaring worse than ever. She's afraid it's something like cancer that doctors are missing. This level of worry and extensive negative workups aligns with somatic symptom disorder, where the patient genuinely feels symptoms and is highly anxious about their health despite no medical explanation. Assessment and approach. Even with her history of negative workups, you treat her complaint seriously. Perform a thorough exam to ensure there truly are no new red flags. Primary survey is clear, no immediate life threats, she's stable. Secondary survey, her abdomen is non-distended, and as noted, exam is benign despite her expressed severe pain. You check for any acute signs, vomiting, GI bleeding, etc. None present. Because she's relatively young and has had prior extensive evaluations, it's unlikely she suddenly has a surgical emergency. But you remain open-minded, like could she have a kidney stone? Her pain is diffuse though, not colicky. History review. She shows you discharge papers from 2 ER visits last month. One diagnosed her with somatic symptom disorder and acute anxiety, another with nonspecific abdominal pain. Follow up with primary care. This reinforces that this is a recurrent issue. Now, you recall that for patients like this, the literature suggests acknowledging the patient's suffering and avoiding excessive interventions that can cause harm. So you proceed with empathy, validation. You tell her, I can see you're in real pain and very worried. We're going to take care of you. Sometimes our bodies feel pain even if tests don't show a clear cause, but that pain is still real. I'm here to help. You thereby legitimize her experience, which helps build trust. Many such patients feel dismissed by the medical system. Gentle reassurance. You mentioned that her vital signs are stable, which is a good sign, no fever or dangerous changes. This may soothe her a bit. Maybe it's not immediately life-threatening if my vitals are okay, she might think. Limit unnecessary treatment. Since she rates 10 out of 10 pain, if you are an ALS provider, you consider analgesics. However, all providers should start with getting the patient into a position they feel most comfortable in. With somatic disorders, opiates are generally not ideal. You opt for a conservative approach, perhaps offering acetaminophen or ibuprofen if she hasn't taken any, something to show you are treating her pain but not jumping to high-risk meds. If protocol allows, maybe a small dose of an IV non-opioid analgesic or even a mild sedative could help, mainly targeting her anxiety, which is amplifying the pain. Avoid frustration. It's easy for providers to become frustrated. The chart might label her as frequent flyer, but you stay professional and compassionate. You certainly never use derogatory terms or convey that she's wasting your time. In fact, you note to yourself that such patients benefit from scheduled care and mental health support, but in the moment, your job is to ensure she's safe and feels cared for. Regardless, your priority is the patient who is in front of you, this one, not the potential patient you may be missing out on. Transport decision. Given she's requesting to go to the hospital, she insists, I need another scan, something's changed this time, I swear. You begin transport. It can be counterproductive to refuse, and from a legal ethical standpoint, she has pain and wants evaluation. It is your duty and legal responsibility to transport her. En route, you continue to talk with her. Interestingly, by just listening to her and providing a calm environment, she reports the pain is slightly less than before. This fits a pattern. Her pain intensifies with stress and diminishes when she feels heard and calmer. At the ED, you give a thorough turnover, mentioning her stable vitals, benign exam, and extensive past workups, as well as her legitimate pain complaints. This helps the ED possibly fast-track a psychiatric consult or at least avoid redundant tests, although they will likely do basic blood work or imaging to be sure nothing acute is happening. The patient is likely to be discharged with advice to follow up with her primary doctor or a mental health professional. Learning points. Somatic symptom disorder cases are challenging. EMS must tread a fine line. Rule out new emergencies. Just because she's called 5 times before and it wasn't serious doesn't guarantee this time isn't. Always check. Provide comfort measures even if you suspect a psychological origin. Pain is pain, and she's in distress. Use empathy to establish trust. Patients with these disorders often feel invalidated. Your validation can itself be therapeutic. Recognize you likely cannot fix the underlying issue on scene. This is an ongoing condition that requires long term management, therapy, consistent primary care. But what you can do is ensure she's not in immediate danger, avoid causing harm, don't give unnecessary high risk interventions, and get her to the appropriate next step. It may be appropriate in some systems to involve community paramedicine or notify a case management program if one exists to help this patient in the long run. Some EMS systems have flags for frequent callers with care plans. Above all, maintain professionalism. These patients can test providers' patience, but they deserve the same standard of care as anyone else. By showing compassion, you uphold the trust in EMS. Also, such patients might gradually become more receptive to mental health referral if each encounter with EMS and doctors is gentle rather than dismissive. Today, you might just be transporting again, but you could plant a seed by saying, have your doctors ever talked with you about stress or anxiety possibly making the pain worse? It's something to consider. The mind and body are connected. If she's not ready to hear it, don't push. If she is, it might open a door for her to consider integrative approaches like therapy, stress management, in addition to medical care. Neurotic disorders require us to blend medical knowledge with strong communication and empathy. EMTs or paramedics are a lifeline for these patients, not only treating their immediate symptoms, but also guiding them towards hope and help. By mastering both the science, recognizing presentations, ruling out medical issues, and the art, therapeutic communication, de escalation of pre hospital care for anxiety related emergencies, you'll improve outcomes and potentially change lives. Remember, keep calm, assess thoroughly, communicate kindly, and care safely. Your influence in those critical moments can turn a terrifying experience into one of relief and trust for the patient. Thank you for joining me and stay safe out there.